Hello everyone. So in clinical practice in day-to-day scenario, it is very common. We often find difficult to differentiate between the pneumonia and pulmonary edema, whether the patient's symptoms, breathing difficulty, respiratory distress, hypoxia, it has been attributed to the respiratory cause or cardiac cause. So whether it is attributed to the pneumonia or cardiac failure. So, how should we approach to differentiate between these two? So, first and foremost is the symptoms. In the pneumonia, we find the symptoms along with the breathing difficulty. Patient might have fever, chest pain, dyspnea, cough. So the associated symptoms, fever, cough, dyspnea, chest pain, so they are predominantly respiratory. They are suggestive of the infective pathology. Then it is more likely to be pneumonia. In case of pulmonary edema, fever might not be present. Fever is not there usually. We have breathing difficulty along with the increased sensation of the pulse rate, tachycardia, various kind of arrhythmias, chest pain, pedal edema, facial swelling, etc. It might be present. So cardiac symptoms like dyspnea, chest pain, pedal edema, palpitation, they are present. So it is more common in pulmonary edema. Then second thing is the risk factors. So risk factors for pneumonia such as diabetics, elderly, alcoholics, history of travel, it might be there. And in the cardiac illness, the risk factors like diabetes, hypertension, dyslipidemia, history of smoking, alcohol, tobacco, etc. might be present, and previous history of any cardiac illness such as history of MI, undergone certain interventional procedures such as angioplasty or bypass, or history of valvular heart disease, cardiomyopathy, such past history, it might be evident in patients with the cardiac illness. Then come to the examination findings. So in patients with the pneumonia, on clinical examination, patients along with the hypoxia, tachycardia, tachypnea, if the pneumonia is severe enough to cause the hypotension, so hypotension it might also be present if it is associated with the septic shock also. And on auscultation, crepitations are particularly limited. If there any particular lobar involvement is there, then that particular region crepitations might be there. And on the x-ray also, that particular area involvement, if it is bilateral diffuse involvement, in case of atypical pneumonia might be there. Otherwise bacterial pneumonia, there is a particular lobar involvement is there. And in case of pulmonary edema, on the chest x-ray, bilateral diffuse infiltrates along with the pleural effusion might be there. Changes on the ECG, if the pre-existing illness or coexisting illness is MI or any valvular heart disease, but ECG changes pertaining to the chamber enlargement, arrhythmia or MI, it might be evident. On echocardiography, it is more helpful to differentiate between the two. On the echocardiography, in case of pulmonary edema, we can evaluate the LV systolic and diastolic function, all the chamber size, whether any stenosis or regurgitation, chamber enlargement, IVC diameter, B lines is there. So accordingly we can be more precise with the diagnosis. Similarly, in the pneumonia, these changes are not there. So it is more helpful in the diagnosis. In the CT scan also, in case of the pulmonary edema, the infiltrates are mainly perihilar in distribution, diffuse bilateral ground glass opacities, along with the pleural effusion. It is there in case of the pulmonary edema, while particular lobar involvement in case of the pneumonia. If it is atypical or viral pneumonia, then also ground glass opacities and bilateral opacities might be there. And another thing is the response to treatment. The pulmonary edema responds dramatically to the diuretics, while we need proper antibiotics, finding the etiology in case of the pneumonia. So these are the main differentiating factors with the pneumonia and pulmonary edema. Other thing is that in the elderly individual, all the typical symptoms, respiratory symptoms such as chest pain, breathing difficulty, coughing sometimes might not be there. They may also just present with the coughing, they may just present with the fever or mild anorexia or confused behavior. So in elderly, all the typical symptoms they are not found. Other investigations such as troponin, TNT, proBNP, these are also very helpful in differentiation of both, and sometimes both of these might be coexisting. Say patients with the respiratory illness might develop acute coronary syndrome, or the pulmonary edema along with the secondary bacterial infection, pneumonia, might also be coexisting. So that also kept in mind. Thank you.